in all of the rooms, it just says telehealth. Is that what it says?
Yep.
Okay.
They all of the jacks should be labeled as telehealth.
Okay.
Connect and at the head of the bed. So then we'll power up.
Where's the power button?
So it is on the side of the cart, located on the right. So if you kind of look in here,
down in there.
yep, it's right on there. So
Does
you
it
want to power
automatically
it up.
turn off?
It,
Because I was restarting it last night and it was off.
so it was probably shut off after we were done using it, just because it should be stored with the power off.
Because I have to restart it every night.
Monday and Thursday, so just twice a week.
Monday and Thursday.
If this is stored
Thursday.
And we're not sure who's gonna do that.
in the back all the time.
Okay, so then it should pull up to the ready screen, and that's really all you have to do. Now, when the neurologist is ready to call in, she'll just pop up on video and start with her exam. So we're going to age you a little bit here. So we have a 75-year-old female who presented to the ER after being found on the floor of her bathroom in the assisted living. Patient was found by the staff at 10 a.m. and was noted to have right-sided weakness, right facial droop, and expressive aphasia. Staff at the assisted living facility last saw her at her baseline at 9:30, so that is her time last known well. Staff called 911 and she presented via EMS. They provided the pre-alert. When the patient comes here with a pre-alert, you're going to activate the stroke code and call United Patient Placement right away. Bring that patient to CT scan, get that non-contrast head CT, wheel her back in here. You can be placing more IVs, blood pressure, kind of working on your exam, asking her questions, all while the neurologist is, you're waiting for the neurologist to pop up on video.
And could they already be on video? Like, hey, you're up and she's at CT, so.
Yep. So if
you guys.
So if they pop up on video and the patient isn't here or isn't in CT, it's always helpful if you have someone in here just letting the neurologist know where the patient's at, and then you can be providing that report at that time as well. All right.
All right. So where are we at in the code, you guys? So I've had a phone conversation, we'll say, with someone there first to determine, where are we at? If it's someone who's presenting late, I might tell you to do the CT and the CTA right away together. If it's someone presenting in the standard early time window, I will, we'll just go with the CT and have the patient come back, so I won't have to make any adjustments there. I listen to the story and we kind of decide together, yep, this is a good stroke code, let's go forward. And then I move toward video connecting after that phone conversation. So the first thing that happens is the phone call to our patient placement, they page it out to me, I call you back, and then we video connect. Make sense?
Yep.
But so what story that you guys gave me on this particular patient?
Okay, so we've got a 75-year-old female who presented to the ED after being found on the floor of the bathroom of her assisted living. She was found by staff at 10 a.m., was known to have right-sided weakness, right facial droop, and expressive aphasia, and she was last at her baseline at 9:30 this morning. And she was brought in by EMS.
So
they did her pre-alert.
Okay.
She went to CT scan. She just got back.
Okay, and so I've gone through the phone conversation while she was headed to CT, and usually I'm connecting just before she gets back from CT or immediately after she gets back, just time-wise, that's usually what happens when you have a go-to-straight to CT model. So you guys, you've gotten one IV in, but you're needing to start another one, so we've got someone starting an IV. The ER doc and I are getting additional history. I'm listening to the patient and collecting that initial part of my NIH stroke scale by history taking to assess aphasia, level of consciousness, that sort of thing. And let's say we're done with that and I say, okay, you guys, I'm going to need a little help doing the exam. And so I'm going to need either the ER doc or the nurse is going to help me out with the exam. And so I usually start with saying, okay, introduce myself to the patient, and assuming that this is an aphasia patient that understands me, I want to set the tone for the patient. So kind of, are you guys familiar with what AIDED is? Where you kind of share with the patient what your role in their care is and make them comfortable. That's something that we try to do. So what's the patient's first name?
Trina.
Katrina. Katrina, I'm Dr. Hansen. I work with the team here at Fergus Falls, and I am working together. We're going to work together as a team here to figure out whether or not what's going on here is a stroke, number one, and then if so, do we have a rescue treatment we can offer you. So it's going to take us just about 15-20 minutes here to just sort through some things and get a decision going. So I'm going to go ahead and work on figuring out what's going on with your examination here. So probably wouldn't expect a response in this aphasic patient, but try to put her at ease as much as we can. So, ma'am, can you tell me how old you are?
75.
Yeah, not so much. Ma'am, can you tell me what month it is? Not so much. I want you to make a fist with that left hand. Make a fist with that left hand. Okay, not understanding me. I want you to close your eyes and open them.
She did it.
Can you see me?
Oh, did she?
Yeah.
You know, I'm going wireless here, which I don't usually do, and it is causing some loss of frames, so I'm not getting the full picture here. So hopefully this won't be the situation usually. All right, so we got our level of consciousness questions and commands all done. And aphasia, she is pretty much a global aphasia, so she's a 3. And then I'm going to ask the nurse who's helping me to get her to look over to one side.
We have a volunteer nurse.
Trina, can you look over
Do
here?
I have a nurse working with me?
There we go.
I have a few nurses to work with.
She's looking over by me.
Okay, she looks
Yep.
over to the left.
Can
Good.
you look
So,
over here?
and then usually in a really severe patient like this, she's going to have a left gaze preference. It's going to be easier for her to look to that side. So you on her right side, can you just get her to look over toward you?
Trina, can you look
What am
over
I supposed to
And
do? I
she's-
don't know my neuro very well.
You're supposed to get. Can you see
Just
this?
have her, get her to look over to the right, make her eyes open.
To the right.
You're right.
So what you can do too is even if you just move from one side of the bed to another, just to see if she's able to track you.
I'm not sure what I'm supposed to be doing as a right hemiparesis with my eyes.
You guys, I apologize. Yeah, so, I'm sorry, it's my patient that's saying that. I'm really losing a lot of frames, so I couldn't even tell it was my aphasic patient talking. Okay, so an aphasic patient, oftentimes they're going to be gaze over to the left. Those frontal eye fields make you look over to the left. And so, yeah, and then it might be a struggle to get her to look over to the right. So the nurse who's on her right side there would maybe say, look over here, yell at her, and get her to try to track over to the right side, try to get her attention and see if you can't get her. And then, Liz, I don't know if you want to come in and just show visual field testing in this case. You're going to just do visual threat like this.
That's when you can go like. Okay. Her whole body jumps. Coming at you.
Half our patients are going to get this.
So that's what you can do if they're not
Image
able to respond.
hugely delayed. I can't even see you doing it yet, guys. So I'll have to wire up for the next code, I think. So anyways, you get the picture. So we're kind of going through it together, and I should be guiding you through what I want you to do with the exam. When it comes to visual field testing, I'm usually saying, okay, to the patient or to you, your nurse is going to put his or her hands up about yay far apart, and they're going to wiggle one hand the other, or they're going to wiggle both together. You look right at your nurse's face and tell them which hand you see wiggling, or if you see both wiggling. And that's how we get that accomplished. And then, go through the motor and the sensory. So now we decided, let's say the patient had come back from CT. We kind of got waylaid a little here trying to do NIH stroke scale, but if I saw the patient coming through the door with that horrible looking facial weakness and gaze to the left, and you show me that her arm's not moving, I don't wait to do the NIH stroke scale to order drug. I've looked at the CT already. I say, let's go ahead and get that drug ordered, and then we go back at the exam to complete it. And then on the CT scan, let's say on this particular CT scan, we can also see that there's a clot sign in the artery. We've not given contrast, but we can see the clot in the artery on the CAT scan. I don't even need the CTA. I can tell you, you need to also mobilize Dr. Randy. So literally within 10 minutes then, we have our code underway, decisions made, treatment happening.
Will she
say
say that,
things
like in
working
the
okay?
middle of the exam, say, let's go ahead and get that TPA mix?
Yep.
So if we're primary nurse, co-coverage nurse, doing the exam with the neurologist, and then we need to leave to go mix, who's gonna stay with to
So
continue?
that's where she might not finish the exam until
Oh,
she's
I see, she
given.
will stop the exam.
Yep, and then you
Okay.
can finish after you start that.
So you don't have to have the
I
completed.
get
Can we just throw it in our pocket?
The idea is to get to that drug as quickly as possible. So I need to, one, know that it's a stroke,
You have to have a
and
second
two,
nurse.
know that there's not blood on the CT. So, and some other historical items, obviously, for exclusion. So, I'm assuming that we kind of talked through that and we made sure that there weren't any big hemorrhagic risks for the TPA.
And so we don't have to have
So
a
we
completed
get to it as fast as we
NIHSS.
can, and then we let everything else
It's
catch
as
up.
long as, so she's just kind of diagnosing, she can see, yep, there's a stroke here, let's get drug going, get that drug going, and then she can finish with that exam.
And VRAD or our radiologist is personally calling her, not doing this over the video.
Yep, they have all of
Okay.
their numbers to contact,
Okay.
so they'll just need to be told who is on for Telestroke, so just let them know who you're connecting with, and then they'll give them a call with the imaging results.
So you know how delayed this image is? I just saw you do the visual field test.
Oh, wow.
That's not good.
I think we need to wire up the next time.
Yeah, yep.
Okay. Any questions, you guys? Very important, that nursing and the Telestroke physician form a strong partnership from the beginning, so that you're anticipating what we need, we're anticipating what you need, we're really working together on this. And so, you guys talk us up to the patient, we'll be talking you up to the patient, and trying to make sure that we're working closely as a team. At the end, as we talked about, it's not a bad idea at all to once the treatment decisions are made, to get on the horn and just talk to each other on the phone away from the patient and say, here's a couple of things that we might have done differently, or, this was a great stroke code, thanks for your help, or whatever it was, that transpired during the code.
All right.
Awesome.
Thanks,
Thank you.